A 74-year-old patient presents with new onset heart failure. He is being diuresed with IV furosemide and generated a tremendous urine output. You decide to check some electrolytes and they're all low. What do you replete first? Potassium, magnesium, sodium, or bicarbonate? So I'll give you 10 seconds for this one. Shouldn't be too hard this time. So the answer here is magnesium. So I was taught this, and then I kind of just cast it aside. So we're going to go over the mechanism. And so the best way to do that is by talking about it with nephrons. So hypomagnesemia and hypokalemia tends to occur with diuresis, and you have to replete magnesium before repleting potassium. So this is a nephron schematic, so I'm sorry, but I'm not sorry. And we need to go over parts of the channels. So loop diuretics cause sodium to be absorbed distally in the nephron. So this is your loop diuretic. And when you have more sodium going down the tubule and it exchanges here, sodium comes in and potassium comes out. So you become hypokalemic. All right, so now we need to go over this part specifically, which is the loop diuretic channel, NKCC2. So notice here there's some potassium leaking out, and that's actually a really critical point. The K that goes into the tubule is what maintains the positive charge in here. And if you have enough of a positive charge in here, that's what drives magnesium reabsorption out of the urine and back into the body. So without this positive charge, magnesium is not as willing to go back in here. Now, a loop diuretic will block this. So if you block this, you get less potassium going out. So if you get less potassium going out, you get less magnesium reabsorption. So this actually drives hypomagnesemia in this mechanism. All right. So to recap, you block the NKCC2 with the loop diuretic, potassium stops leaking out, and so magnesium actually doesn't get reabsorbed, and you also start losing magnesium. Now let's talk about another channel, which is the ROM-K channel. So it's similar to that potassium leak channel, but it's distal. And what's really interesting about this is potassium just kind of leaking out. Magnesium inhibits this channel, which means that if you have enough magnesium circulating, potassium does not come out. But if your magnesium is low, potassium starts leaking out. So it looks like the loop diuretic caused hypokalemia. The hypokalemia actually prevents magnesium from being reabsorbed. And because the magnesium is low, more potassium comes out. So to uncouple all of this, repleting the magnesium first will really help. So to review everything again, diuresis causes potassium and magnesium to be excreted by the kidneys. Magnesium inhibits potassium excretion. And if magnesium is low, potassium excretion continues no matter how much potassium is administered. So please replete magnesium before repleting potassium. That's all I got. Any questions?
So on a practical level, if you were to be repleting both at once, like on the wards, would you just have the nurse give the magnesium first?
I think if you're really not in a crunch for time, I would do the magnesium first. This really applies more to patients who are actively being diuresed in maybe like a CCU or PCU level of care, where I think this is more likely to cause arrhythmias, and then you have problems. All right. Thanks, everybody.